So the initial test is CK creatine kinase will be raised, and to confirm the diagnosis, we'll do a muscle biopsy, and muscle biopsy will show absence of dystrophin protein, which is usually present in striated muscles. Due to mutation in this DMD genes, there is no dystrophin protein in striated muscles, which result in proximal muscle weakness, and the disease is known as Duchenne muscular dystrophy. Remember that Becker's muscular dystrophy is also similar to Duchenne muscular dystrophy, but you can say that Becker's muscular dystrophy is a less severe form of DMD, because in Duchenne muscular dystrophy, this dystrophin protein is absent, while in Becker's muscular dystrophy, the protein is present, but there is a defect in that protein, which result in less severe symptoms. So in Plab 1 exam, you won't usually be asked to differentiate between DMD and Becker's muscular dystrophy. You will only be asked about its inheritance pattern or question about its inherited pattern. It is an X-linked recessive disease, and we have already discussed that X-linked recessive diseases, they only affect males. Now, our next topic is trisomy 13, trisomy 18, trisomy 21. Trisomy 13 is known as Patau syndrome, trisomy 18, E for 18 and E for Edward. So trisomy 18 is Edward syndrome, and trisomy 21 is Down syndrome. So what is trisomy 13? Trisomy 13 is when an extra copy of, instead of 2 copies of chromosome number 13, 3 copies of chromosome number 13 are present. Due to an extra copy of chromosome number 13, what happens? The child will have a prominent calcaneus, that is also known as rocker bottom feet, cleft lip and palate. You can see in this diagram this cleft lip and palate, microcephaly and microphthalmia and polydactyly. While trisomy 18 is known as Edward syndrome, prominent calcaneus and prominent occiput. So in trisomy 18, you can see that there are 2 prominent, that is bottom, prominent calcaneus, and top, that is occiput. So 2 prominent and 2 small, small head and small jaw. And hands are clenched into fist with overriding fingers. While on the other hand, trisomy 13 or Tau syndrome has 2 smalls and many fingers, microcephaly and microphthalmia, along with many fingers. Then your diagnosis will be trisomy 13 or Patau syndrome. And we are all familiar with trisomy 21 or Down syndrome. Starting from the eyes, there is upward slant to the eyes. Then there's a small nose with depressed nasal bridge, abnormally shaped ears, and small mouth and enlarged tongue. So these are the features of Down syndrome that are present in the face. In eyes, there is upward slant to the eyes, small nose with depressed nasal bridge, abnormally shaped ears, and small mouth and enlarged tongue. Now, the other abnormalities that can be present in Down syndrome is single deep crease across the palm, joint laxity, space between first and second toe, and duodenal atresia. And duodenal atresia, whenever there is duodenal atresia, double bubble sign will be present on X-ray. For example, a neonate's chest X-ray shows double bubble sign. He has a flat occiput and low sets of ears. So someone with a double bubble signs and low sets of ear, your diagnosis will be Down syndrome or trisomy 21. Congenital adrenal hyperplasia was discussed in endocrinology chapter, so we'll not discuss it here. Now our next topic is Klinefelter syndrome. Turner syndrome was when an X chromosome was missing, and that was a female. While in Klinefelter syndrome, a male has an extra X chromosome, so double XY. What will happen due to this an extra chromosome? The male will have gynecomastia, facial hair, low facial hair. Because of this extra X chromosome, feministic features will be present, such as gynecomastia, low facial hair, estrogen will be high, testosterone will be low, long limbs, tall and slim, elevated FSH and LH, and aggressive behavior. Low testosterone, high estrogen. So, because of extra chromosome, feministic features will be present. Even the female hormones will be high. And due to this high hormones, high female hormones, the person will be sterile, or the person will have hypogonadism, small testes, and azoospermia or no sperm in the semen. So male infertility. So a long, tall, slim, infertile male, your diagnosis will be Klinefelter syndrome. Another genetic disease in which the person is male and he's tall and slim is Marfan syndrome. But in Marfan syndrome, infertility is usually not present, and these features such as high estrogen and elevated FSH and LH, they are also not present. The common presenting feature of Marfan syndrome is spontaneous pneumothorax and hypermobile joints. So a tall, thin male with hypermobile joints, your diagnosis will be Marfan syndrome. The diagnosis of Klinefelter syndrome is confirmed by karyotyping, that is chromosomal analysis. So tall, thin boy with spontaneous pneumothorax and flexible joints and myopia, your diagnosis will be Marfan syndrome. DJAR syndrome is also a genetic disorder. Whenever you see absent thymic shadow in Plab 1, then your diagnosis should be DJAR syndrome. Now, Huntington disease, you need to remember 3 points to make a diagnosis of Huntington disease. That is cognitive impairment plus involuntary movement of a limb plus family history of the same disease. So if these 3 criteria are present, then your diagnosis will be Huntington disease. Huntington disease is an autosomal dominant. So if one parent is affected, 50% of the children will be affected and 25% of the grandchildren will be affected. So how a patient of Huntington disease will present to you? There will be personality changes, because cognitive impairment means personality changes plus memory impairment plus chorea, that is involuntary limb movement, and plus family history. For example, an elderly man present with a history of changes in mood and personality for the last year, which were followed by poor memory and concentration. So there is cognitive impairment. Then he developed progressive fidgety movements and choreiform movements. So cognitive impairment plus involuntary or jerky movements of the limbs, your diagnosis will be Huntington disease. Autosomal dominant disease, Huntington disease is an autosomal dominant disease with anticipation. What is anticipation? The symptoms in the next generation appear earlier and earlier. For example, if the father has developed the disease at 50 years, his son will develop the disease at 40 years, and his grandson will develop the disease at 30 years. So this phenomena is known as anticipation. Now, how to investigate potential genetic diseases? before pregnancy. If someone want to investigate a potential genetic disease, then our method should be pre-implantation genetic diagnosis. What is pre-implantation genetic diagnosis? Pre-implantation genetic diagnosis is done before pregnancy. It is suitable for serious genetic diseases such as cystic fibrosis and sickle cell anemia when there is a strong family history or parent is a carrier. So if there is a strong family history of a serious genetic disease, or if there is a family history that the parent is a carrier, then we can do pre-implantation genetic diagnosis. How it is done? It is done, fertilization is done in vitro in the laboratory, and then embryos are tested for genetic abnormalities, and one or two unaffected embryos are then implanted into the uterus. So that's why it is important for serious diseases such as cystic fibrosis and sickle cell anemia or any other serious genetic disease. Now, if someone want to do a genetic testing during the 11 to 14, then chorionic villus sampling will be done. And after 14 weeks or between 15 to 20 weeks of pregnancy, amniocentesis will be done. Amniocentesis is not done before 15 weeks of gestation because in the initial weeks, the amount of amniotic fluid is very less. And if amniocentesis is done before 15 weeks of pregnancy, then the chances of abortion are very high. So that's why from 11 to 14 weeks of pregnancy, chorionic villus sampling is done, while after 14 weeks or between 15 to 20 weeks of pregnancy, amniocentesis is done. For example, a woman is planning to get pregnant soon, but she is afraid as she has a family history of cystic fibrosis. What is the earliest possible investigation? So she is not pregnant yet. She is planning to get pregnant and she has a history of cystic fibrosis. So what is the earliest possible investigation? Pre-implantation genetic diagnosis. Hyperelasticity of skin, hypermobility of joints, plus minus blue sclera. Diagnosis will be Ehlers-Danlos syndrome. Next topic is neurofibromatosis. What is neurofibromatosis? Neurofibromatosis is an autosomal dominant disease. What is the diagnostic criteria for neurofibromatosis? 6 or more cafe-Ullart macules. 6 or more cafe-Ullart macules. 2 or more cutaneous or subcutaneous neurofibromas or plexiform neurofibromas. Axillary or groin freckling. Let me show you a diagram of cafe-Ullart spot. Just give me a minute. So you can see in this diagram, these spots or these macules, these flat coffee colored macules, these are known as cafe-Ullart spots. This one, this one, this one, and this one. And these tumor-like growth on the skin, they are neurofibromas. They can be cutaneous neurofibromas, that is, they are present in the skin, and if the neurofibromas they are present in the deep tissues, then they are known as plexiform neurofibromas. So cafe-Ullart spots or neurofibromas, plexiform neurofibromas or cutaneous neurofibromas. Now, other diagnostic criteria for neurofibromatosis is sphenoid wing dysplasia. You can see in this diagram that there is no sphenoid bone. In the orbit, there is no sphenoid bone. So there will be herniation of the brain tissue. You can see in this diagram as well. And you can see on this radiology, a CT scan of the brain, you can see that here you can see this white structure is sphenoid bone, but on this side there is no sphenoid bone, and this brain has herniated into the orbit. So sphenoid wing dysplasia is another criteria. Now, in this diagram, you can see that there is anterior bending of the tibia, anterior bending of the tibial bone, which result in the fracture. In this diagram or in this X-ray, you can see in this one, it is more clear that due to this anterior bending of the tibia, a fracture has occurred, which result in the formation of a pseudo joint. This is known as pseudarthrosis. So cafe Ullard spots, cutaneous or plexiform neurofibromas, sphenoid wing dysplasia, and pseudarthrosis or pseudoarthrosis, formation of a false joint due to fracture of the tibia. These are some criteria to make a diagnosis of neurofibromatosis. So 6 or more cafe-Ullard macules, 2 or more subcutaneous neurofibroma, or 1 plexiform neurofibroma, axillary or groin freckling, optic pathway glioma, bony dysplasia such as sphenoid wing dysplasia, bowing of long bones which result in pseudarthrosis, and first degree relative with neurofibromatosis type 1. Or 2 or more Licht nodules. What are Licht nodules? These are basically hyperpigmented nodules that are present on the iris, which can be seen on slit lamp examination. So these are the diagnostic criteria to make a diagnosis of neurofibromatosis. There are two types of neurofibromatosis. One is type 1 neurofibromatosis. Type 1 neurofibromatosis is presents more with skin lesions, such as cafe-Ullard spots, axillary or groin freckling, scoliosis, and associated with pheochromocytoma. While neurofibromatosis type 2, it presents with CNS tumors, such as bilateral acoustic neuroma, multiple intracranial schwannoma, and meningiomas. For example, a pregnant 31-year female has bilateral cerebropontine tumor, bilateral sensorineural hearing loss, and multiple cafe-Ullard spots. What is the possibility that her coming baby to be affected of the same condition as her mother or so the diagnosis here is neurofibromatosis. Neurofibromatosis is an autosomal dominant condition, and autosomal dominant condition, 50% of the children will be affected and 50% will be unaffected. Now, what you are going to do with a woman with a strong family history of ovarian cancer. So if someone has a strong family history of ovarian cancer and she is worried about herself that if she has the disease or not, then you will do a pelvic ultrasound. And if ultrasound is unremarkable, then you will do genetic counseling for full assessment of risk. And if on genetic testing, the mutations such as BRCA mutations are present, or if there is high risk, if the patient is high risk, then we will offer the patient prophylactic salpingo-oophorectomy. That is removal of the fallopian tubes along with the ovaries. So someone is worried about developing an ovarian cancer because she has a strong family history of ovarian cancer, you will do pelvic ultrasound. And if pelvic ultrasound is unremarkable, you will do genetic counseling. And if the person is high risk after genetic testing, then you will offer prophylactic salpingo-oophorectomy. And if there are manifestation of ovarian cancers, then we have discussed in gynecology that we'll do ultrasound and CA125 levels. For example, a 40-year-old female has her two sisters diagnosed with ovarian carcinoma. So this person has a family history of ovarian carcinoma. So the first thing that we need to do is to do an pelvic ultrasound. But in this case, she has done pelvic ultrasound, which was unremarkable. What is the next step? So the next step should be genetic counseling. Now, the coming keys have only discussed the examples of the scenarios or the diseases or the inheritance pattern that we discussed in the beginning of the lecture. So you can practice them after the lecture. Now, let's do this example. So from the pedigree below, what is the chances of unborn male baby to be affected by Duchenne muscular dystrophy? So DMD is an X-linked recessive disease. So in this pedigree, you can see that, remember that in Plab 1 exam or in general, the circle represents the females and the squares represent the males. And the half-filled square or circle will represent a carrier, and the fully filled square or a circle will represent the affected person. So now, what is the question they are asking? What is the chance of unborn male baby to be affected by Duchenne muscular dystrophy? We can see that in this pedigree that the mother is a carrier. Mother is a carrier. What does it mean? The mother has one normal X chromosome and one abnormal X chromosome. Now she wanted to know that what are the chances of her unborn baby to be affected. So 50% chance that this baby will get the normal X chromosome, and 50% is the chance that he will get an abnormal X chromosome. So 1 in 2 chances that, or 50% chance is that the child will have DMD or Duchenne muscular dystrophy. Now, another example of what kind of questions can be asked in the Plab 1. So what is the mode of inheritance shown in the following pedigree? So as I told you before that circle represent the females and square they represent males, and fully filled circles they represent the affected females, and fully filled squares with they represent the affected males. And if there's a cross on this square and or circle, then it means that person is deceased. So by looking at this pedigree, can somebody tell me what is the pattern of inheritance? First of all, let's decide, is it an X-linked inheritance or is it an autosomal dominant inheritance? Sorry. First of all, let's decide, is it X-linked inheritance or autosomal inheritance? So to decide that, is it an autosomal or X-linked, we'll see that In the first generation, males are affected, and in the second generation, females are affected. So males and females both are affected. So we can say that it's an autosomal pattern of inheritance. Is that right? If only males were affected, then we could have said that it is an X-linked pattern of inheritance. So it is an autosomal pattern of inheritance. Now I will decide, is it an autosomal recessive or is it autosomal dominant? So how we are going to decide that? Let's suppose it's an autosomal recessive. So for autosomal recessive, we can suppose that this male should have two abnormal genes, because we are supposing that this is an autosomal recessive pattern. So we can say that because we have decided, suppose that it is an autosomal recessive pattern. So this person should have both abnormal genes. Both the genes should be defective. But you can see that in their children, there is no carrier state. One child is affected and one is unaffected, and there is no carrier. So if it were to be autosomal recessive, there should be a carrier should have been present, because both the genes are defective, and if both the genes are effective, only a single gene cannot cause the disease. You can see that here this male is also affected. So he needs two abnormal genes to have the disease, but he will get one normal from the mother. So if it were to be autosomal recessive, this person should not have the disease. So we can say that this is not an autosomal recessive pattern, but it's an autosomal dominant pattern. So the diagnosis here is, the pattern shown here is autosomal dominant. So again, it's a two-step process. First of all, you need to decide if it's an X-linked inheritance or if it's an autosomal inheritance. If males and females both are affected, then you will say it's an autosomal inheritance. And if only males are affected, then you will say it's an X-linked inheritance. Now to decide about autosomal dominant or in recessive inheritance, we need to go a little deep, and we should start from the parents. You can see that this parent is affected, and an affected parent with a recessive disease, an affected child or an affected male child cannot be produced if the mother is normal. So that's why we said that it's an autosomal dominant inheritance and not autosomal recessive inheritance. I hope this example is clear to everyone, because a question can be asked in tab 1 like this as well, that they will show you the pedigree and ask you about the mode of inheritance. Are there any questions? So